Hi, and welcome to the positioning for the hip and the femur. We're going to start with the hip first. With the hip, you will use a 10 by 12. There are two positions that we are going to do, an AP unilateral hip and a what's called a frog leg hip. So when we're looking at the AP unilateral hip, we want to make sure that we are familiar with our landmarks. You need to know where your iliac crest is and that ACES. When we actually measure from the ACES down to the symphysis pubis, directly in the center is where that acetabulum falls, and that's where your head of your femur is going to fall. And we want to make sure that those are nicely centered to our image receptor. So when we're doing an AP unilateral hip, I want you to place your cassette so that it's a 10 by 12 lengthwise, 40-inch sit to the bucky tray, so you do have a grid cap that you're using for this. We are going to use about 80 kVp at 20 mass. You can use shielding, although I encourage you not to unless they're young in childbirth age, because sometimes that can clip off the area of interest. Central ray is going to come right through the mid-femoral joint. So we have approximately 1/3 of our femur that's going to be included on our image receptor. The hip joint or space and acetabulum will be well visualized. Your lesser trochanter will not be in profile because you're going to take those feet, you're going to turn them internally 15 to 20 degrees and form that teepee to bring that greater trochanter into profile. Our frog leg, you're still using the 10 by 12 lengthwise. Same technique. You're still centering on that acetabulum and femoral head. The only difference is you're taking that leg, you're lifting it up so that the knee is pointed towards the ceiling, and then you're laying it out to the side. So here you abduct your femur 45 degrees. Most people are not going to be able to lay it down flat on the table, so if you can get them to abduct partially, that's great. And then you're going to center to the mid-femoral neck again. So in profile, our lesser trochanter, you should be able to see the acetabulum and the head of the femur. Again, your technique is about 80 kVp at 20 mass. If you are unable to do that unilateral or frog lateral on a trauma patient, the one thing you need to keep in mind, and same thing for the pelvis, if it's a trauma situation, we will not abduct those toes so that they're touching. We're going to leave them pointing out into a natural position. So every once in a while you're going to have a patient that comes in for a trauma, we can't move them. We're going to do what's known as the Danellis-Miller method. So here you have your grid cap with your grid, with your 14 by 17 cassette. Place that in your grid cap, use the film holder if you have one available. You're literally going to prop that other leg up and out of the way, and you're going to position your tube so that you're shooting through that femoral neck, and you have to match that angle of how your cassette is placed with your tube. Your central ray is still going to come through the patient's femoral neck and onto your cassette. Your image is going to look something like this. You need to have the acetabulum and a portion of the femur on your film. We do have a couple special procedure films, Judet method. We're going to do some films on these, but I'm not going to require them for evals. If you have to do a Judet method, you're going to find that ACES, and your central ray is going to be 2 inches distal to the upside of that ACES, and then you're going to do 2 inches distal to the medial down ACES. And this is what your films are going to look like. So every once in a while you'll have to do an RPO and LPO position on your patient for these Judet methods. Again, not everyone does them, and they're not done very often. Your book also talks about the PA axial oblique methods. I have not seen your situations or your clinical sites do these, but I wanted to make sure you're aware of them in case you do come across them. Modified axiolateral, which is called your Nakayama method, is the exact same thing as your Danielus Miller. The only difference is this leg, because there'll be trauma to both legs, you can't raise it. So you're actually coming down and through that midfemoral neck on the affected side, and you are not taking the other leg and moving it out of the way. So you'll get an image that still looks similar to your Danielus Miller. Your femur, you're still going to do an AP hip and a unilateral hip, but you're going to use 14x17. So your proximal portions will be the same as you did for your hip. The distal portions will be different. So you will have an AP femur for the distal, and you'll do an AP femur for the proximal. Your distal AP femur, you're going to rotate that leg about 5 degrees internally, and you're going to center to the mid shaft. So basically take the bottom of your image receptor, place it down by the knee joint, center on the mid shaft of your femur. It's not going to get the full femur, and then you're going to do a separate film to get the proximal portion of that femur. So your film's going to look something like this. You're going to be missing that head of the femur, and you're going to get that on the second film. For the distal portion of the femur, you're going to lay your person laterally, and you're going to center again to that mid shaft, making sure that you include the distal portion of the knee. Your patient centered just like they would for the lateral knee that we learned last semester. It's just your central rays going up higher, and you're not putting that 5-degree angle towards the head. So this is what it looks like. You have a true lateral, and you're centering to the midpoint range of that image receptor. If your patient can't roll, you can do a cross-table lateral on them, and your image is going to look like this. Again, you will not have the proximal portion of the femoral head. You're going to take a separate picture, a unilateral frog leg on that, and then you should be able to see that on that portion. So it'll look something like this when you go and raise your image receptor up, and then you're going to take that center again to the midshaft of the femur, and you'll get that proximal portion, but your distal portion will be missing. And if you cannot get that top portion, you'll have to do a Danielus Miller in addition to that cross-table lateral that you've taken. So again, if it's a non-trauma situation, toes can touch. If it's a trauma situation, you cannot touch the toes. So you'll do your proximal femur just like you did your hips.